I am Ken Sherman from the University of Cincinnati, and I am delighted to be able to share with you today my thoughts about hepatitis B prevention and management, what happens when the guidelines fail. I would like to thank Donna Jacobson and her IAS-USA team for organizing this, putting it together, inviting me to give this talk. And I've structured this around the most common and vexing questions that I get associated with hepatitis B. In an average week, I receive 2 to 5 calls regarding hepatitis B management, more than any other individual subject area. And the way I have structured this is to use a case-based presentation and try and answer some of those key questions that typically come up. In addition, many of you have contributed questions, which I have reviewed, and I will try to answer many of those during the talk, and there'll be time at the end for a question and answer session to continue that process. This program is a live activity designated for 1.25 AMA or other type of CME credits, and it's approved for ABIM mock points as well, also for nursing, pharmacy, and pharmacotherapy credits. Generous support for this activity has been received from the following sponsors or contributors. There are some poll questions, and a separate window will show the poll question. Choose your response for the poll, and responses will be displayed after the poll closes. You can also submit questions using a Q&A button. Please put in your first and last name in order to have your questions addressed, and most will be answered at the end of the webinar. We're going to start with this question just to get a sense of our audience. How many patients do you see in your clinic with hepatitis B? Go ahead and answer. Okay, so we have a nice mix of answers regarding this, ranging from greater than 50 to the other end of the spectrum with none. And how many patients with Hep B and HIV do you see in your clinic per year? And go ahead and answer that based upon the categories listed. Again, a nice range of answers, including about 30% that do not see co-infected patients in their clinic, and some seeing greater than 50. So this slide shows my disclosures, and we will continue. Our learning objectives include describing current principles of hepatitis B prevention, risk of vaccine failure in immunosuppressed populations, determining when to treat Hep B and if such treatment should be discontinued, and describing the risks associated with occult Hep B and when monitoring and treatment might be indicated. We're going to start with a couple of pre-test questions. Please respond to these. Which is true regarding acute hepatitis B? Acute Hep B in adults frequently leads to fulminant hepatic failure. Acute hepatitis B in immunocompetent adults frequently leads to chronicity. Acute Hep B should usually be treated with antivirals when ALT is greater than 1,000 international units per liter, or acute Hep B should be treated prior to consideration for liver transplantation. Go ahead and put in your responses. Okay, I am not going to reveal the answer at this point. We'll be going through this again at the end. And here's a second question. Which is true regarding suppressive therapy for chronic hepatitis B? It leads to 95% viral undetectability in HBV/HIV co-infected persons within 6 months. It may be stopped after 1 year in most patients. It is often indicated in persons with normal or near normal ALT levels, or it leads to functional cure in more than 50% of cases. Go ahead and provide your response, please. Okay, great, thank you. Okay, we're going to start with a little bit of background in terms of epidemiology, staging, and life cycle. So, globally, about 2 billion people have been exposed to hepatitis B, leading to 350 million people living with chronic hepatitis B infection. Among those with HIV, this Venn diagram shows the co-infected subset, which is thought to range from 4 to 8 million co-infected persons worldwide. In the setting of co-infection, we began to really understand the problem with older data from the MAX cohort provided many years ago by Chloe Teo. In this study, we looked at the liver-related mortality per 1,000 patient years in various groups, including those with HBV alone versus those with HIV or those with HIV-HBV co-infection. And obviously the risk was very high in that group. In the DAD study, independent predictors of liver-related death in the setting of HIV were examined, and a number of factors appeared to be associated with a higher relative risk of death. And among those was the presence of hepatitis B, as shown here. And more recently, the NA Accord study looked at the risk of end-stage liver disease, which is defined as the presence of ascites with or without SBP, bleeding varices, encephalopathy, or hepatoma in this population, and performed across 3 different eras in the use of antiretroviral therapy. I should note that the ESLD events described are all indications for consideration for liver transplantation. We can see that those with HIV-HBV co-infection had very high rates of incident end-stage liver disease, and they were higher than those with HIV-HCV co-infection. Triple infection was even worse. There was no reduction in end-stage liver disease risk over 3 ART eras. And in a more recent analysis of the NA Accord focused on HBV/HIV by Vince Low Ray, we could see that these factors were were found to be directly associated with end-stage liver disease, the presence of diabetes, race as non-Black, CD4 less than 200, and not surprisingly, those who at the time of the analysis had higher FIB4s indicating the presence of advanced fibrosis, because those patients already had progressed along a continuum of progression of liver disease in terms of fibrosis. Let's take a look at the life cycle, which is rather complex and is important to understand in relation to our thoughts about intervention and treatment, as well as chronicity and long-term management. So the hepatitis B virus will bind a hepatocyte using the sodium tarcalate co-receptor protein. It enters the cell and uncoats, losing the surface antigen coat, and then further uncoats, leading to a relaxed coil DNA, which is transferred by an active process into the nucleus of the hepatocyte. It's here that a mini chromosome, which is called CCC DNA, or covalently closed circular DNA, is formed. The CCC DNA becomes the source of the transcription of mRNAs, either a pre-genomic RNA or the RNAs that will be used for X, pre-surface and surface proteins. Off the pgRNA, we form proteins for hepatitis E antigen. The polymerase and core proteins are translated. And off of the other side, as thinking of it, it's not really a side, but a different portion of the genome, we have the surface antigen proteins and the X protein, which is involved in transactivation and is thought to play an important role in the development of liver cancer. The surface antigen pre-SNS proteins are further put together or broken into their requisite components necessary at the level of the endoplasmic reticulum. When there's active transcription taking place associated with replication, the HBe antigen is secreted, and the pre-genomic RNA and polymerase are packaged into a newly forming capsid using the core proteins. These are then reverse transcribed using the polymerase, which has a reverse transcriptase function, back into a relaxed coil DNA. So back to where we started over here, and then further enveloped in the endoplasmic reticulum, where eventually a completed virion is budded out. Now, hepatitis B has a unique ability to also submit subviral particles. And for many years, these particles, which can be seen on electron microscopy as filaments or small circular particles, as opposed to the full virus or Dane particle, was thought to be a reflection of some sort of a problem with the virus, that it was inefficient and produced all of this excess antigen relative to the virus's needs of coding a complete genome. But now we understand that actually these excess proteins play an important role in causing immune exhaustion and limiting the body's or host's immune response, leading to the maintenance of the chronic disease state. Now, the stages of disease are shown here, and I'm going to review them. I will say that in recent years, there has been, within the hepatology community, considerable discussion and argument about the correct terminology the correct words for what is happening at each of these stages, and an effort by the European Association for the Study of Liver Disease to completely eliminate this terminology of disease stages and refer to chronic hepatitis, subdividing it into e antigen positive or negative, and then characterizing the degree of liver disease present. But for the purpose of today's discussion, I'm going to run through the phases that are traditionally used, particularly still in the United States. Following infection, particularly in a young person or at birth from vertical transmission, we see an immune tolerant phase with high levels of DNA replication and low levels of ALT, where ALT is a marker of inflammation and injury. And that's occurring because the immune system, particularly in a young person, is not awake, and in fact may recognize infection present at birth as self for a period of time and not try to eliminate the virus. And so we call that an immune tolerant phase. Again, arguments about the terminology because there are immune processes taking place during this period. At some point, which can be 20, 30 years later for someone who acquires disease in early life, we see the immune system wake up in a subset of people that are infected. And this leads to a waxing and waning battle of increases and decreases in ALT versus HBV DNA. In this period, most of the patients are HBeAg positive, e antigen positive, and that's an e antigen positive chronic hepatitis. This is where most of the injury takes place, leading to scar and fibrosis. Eventually, if the immune system wins, that person enters a relatively inactive phase. E antigen disappears, e antibody appears, and we have this period of low level of ALT, so low level of inflammation causing ALT to rise, presumably low level of fibrosis progression risk, and low levels of HBV DNA because replication is relatively limited to small nests of cells. However, at any point, that person can reactivate, particularly following exposure to some sort of immunosuppressing event, whether it's exogenous, associated with receiving chemotherapy or perhaps steroids, or due to an infection such as HIV. Now, there's one other stage that we need to think about, and that is occult Hep B. In occult Hep B, the person is hepatitis B surface antigen negative in their serum, but often anti-core is present without anti-HBs. And that's because there actually is an active infection, and we don't see the anti-HBs because it's being bound up in the low levels that it's present. The HBV DNA is positive in the serum and or the liver. And the significance of this is very important in the setting of transplant, where you could take a person who has occult Hep B, transplant them into a surface antibody negative person, and cause recrudescence of disease or a new disease in that individual who never had Hep B before. In HIV, where there are very high rates of intermittent occult Hep B reported in various series as an independent cause of development of liver cancer, or as a source of recurrence after HCV cure, or in the setting of chemotherapy. So part of today's talk in the title is what to do when guidelines fail you. And to talk about that, we first have to talk about the guidelines. There are a lot of guidelines. I'm going to mention a number of these today, and I will tell you that there are at least 30 other country-specific guidelines or other smaller society guidelines that impact the management within various groups that might refer to those guidelines. When guidelines are present at this degree of numbers, it's because there is uncertainty. And there's uncertainty because there's still a lot that we don't know about hepatitis B clinical management, even after knowing about hepatitis B as a disease entity since its discovery by Dr. Blumberg in 1965. So we have a disease that has a complex life cycle that we see in a cross-sectional way when encountering a patient, and which has a host of different presentations and variations in the management that are attempted to be accounted for by experts who contribute to these guidelines. I've been part of various guideline committees, and I guess I should disclose up front that at this time, I am part of the up-to-date guidelines with Chloe Teo for those with HBV and HIV co-infection. So we're going to be using the guidelines as we talk about cases and show where some of the problems arise. Here's our first case. 36-year-old Asian woman with a history of hepatitis B infection that was diagnosed 2 years ago by her primary care physician. She had no history of known hepatitis, but she was born in Korea and reports that her mother had hepatitis B and did die of hepatocellular carcinoma at age 50. On testing, her serum ALT is 31. Her hepatitis B DNA is high, 2 × 10⁷. Her HBe antigen is positive and anti-HBe is negative. She's frightened about her mother's hepatocellular carcinoma history and was initially referred to a gastroenterologist in the community who told her there's nothing to worry about. But her primary care physician, upon hearing of her continuing concern, suggested she obtain a second opinion from a hepatologist. So let's see what the guidelines say about a case like this. The AASLD guideline says, monitor if HBV DNA is greater than 10⁶ and ALT is less than 35 for a man or 25 for a woman, but treat if age greater than 40 with normal ALT and HBV greater than 1 million international units per liter, or if a liver biopsy shows necroinflammation or fibrosis. So that alone gives you some idea of the complexity of what we're thinking about. In the local lab where this patient's ALT was tested, normal was up to 55 for an ALT. There was no sex-specific ALT normals listed by the local lab. And so here in a guideline, we have a differentiation by men and women, and that's appropriate because women have lower ALTs than men. And it depends upon DNA, but age is a factor, and liver biopsy can perhaps change your decision regardless. The European Association for the Study of Liver says, monitor if HBV DNA greater than 10⁷ and ALT is less than 40, and if there are no signs of chronic hepatitis. Treat if ALT greater than 30, regardless of the severity of the lesions, if age greater than 30, or patients with family history of HCC or cirrhosis can also be treated. APASL, the Asian Pacific Association for the Study of Liver Disease. Monitor if the HBV DNA is high, greater than 2 times 10 to the 6th or 7th. If the age is less than 30, liver biopsy if age greater than 35, or if there's a family history of HCC or cirrhosis, or if non-invasive tests suggest evidence of fibrosis or persistently elevated ALT. And then if you do the biopsy, treat if the activity level greater than greater than or equal to 2, or fibrosis greater than or equal to 2. Up to date, if HBV DNA greater than 20,000, but ALT less than 2 times the upper limit of normal, 50, treatment is not recommended unless the patient's greater than 40 or has family history of HCC. Monitor and treatment considered if ALT becomes greater than 2 times the upper limit of normal. And liver biopsy shows severe and moderate inflammation or fibrosis greater than or equal to F2. Wow. So you could see why I get phone calls. What do we do? Because if someone looks at even 2 sets of guidelines, they may get conflicting answers in terms of what are we going to do now. So let's talk about treatment. Treatment has different goals, and we need to start by talking about what those goals are. So we frequently talk about suppression, and suppression means suppression of HBV DNA. And that suppression should be today to undetectable using a sensitive PCR-based assay, which typically has a lower limit of sensitivity of around 20 international units per ml of virus, of viral DNA. But it's important to know that that number and our ability to test has varied over even recent years. Tests have become more sensitive in general over time. And studies, if you read the literature, including those that are often used in the development of the guidelines, because that may be the only study available, used very different cutoffs over the years. So different tests, different cutoffs. Some may have been quite higher and still say that they achieved suppression, whereas today we might say that that patient remains not suppressed. And so when we interpret and try to determine what to do, it's also in light of what does suppression mean for the particular studies that led to thinking about a particular recommendation. Seroconversion. So seroconversion is that transition from a more active hepatitis to a less active or inactive state. And in the literature, some studies have only required hepatitis B E antigen negative, but today we usually talk about hepatitis B antigen negative, E antibody positive. So a full conversion requires both elements. And then we talk about durability, and we're going to spend some more time on durability, but durability means that not just that you achieve that goal here, seroconversion, but that it doesn't go back when you stop therapy, because if it goes back, then you're sort of back to where you started. Now, in the last few years, we're talking more and more about functional cure. Functional cure is no longer having HBsAg detectable and should include the appearance of anti-HBs, because again, some people are using definitions that say we lose HBsAg, but if they don't develop antibody, there's a much higher chance that it will not be durable and could swing back the other way. And the sort of aspirational state is true cure. And true cure would be the loss of cccDNA mini chromosome in the liver, which is not available to clinicians to detect, requires liver biopsy at this time, outside of very specialized research studies looking at some other methodologies to determine if there might be a functional cure. So this is aspirational both in its difficulty in detecting, no commercially available tests for true cure, and that in fact it's almost impossible to achieve as far as we know. These are our tools. These are the agents we have to deal with. On the left are the HBV approved agents in the United States, approved by the FDA. In reality, we routinely now use only 3 of these: tenofovir, diprovoxil, tenofovir alafenamide, and entecavir. Pegylated interferon is used more frequently in Europe. It certainly is approved and can be used, but it is not something that is routinely used in most places in the United States. And then there are HIV active agents that have reverse transcriptase activity and are therefore active against hepatitis B as well: tenofovir emtricitabine combinations and emtricitabine alone. The treatment outcomes can be measured against any of those markers that I talked about. So undetectable HBV DNA, HBeAg seroconversion, or functional cure, HBsAg loss. And I highlighted those both for e antigen positive on top and e antigen negative on the bottom to show you how rare this really is in the real world, regardless of what treatment you use. Though there are studies that go as high as 15% for peg interferon nuke with lamivudine treatments achieving functional cure with HBsAg loss, the overall rates are quite low, and though they do improve with years of therapy, they remain quite low, as we'll see in some data, even after a decade or longer of therapy. This looks at that HBsAg clearance or functional cure in patients with HBV HIV co-infection. This is the French national cohort study, followed for 12 years. Patients had chronic hepatitis B. They were treated with a therapy that was HBV active that did not include entecavir or interferon. And the results, I apologize that the axis is small. Those are cumulative probabilities of loss, and the left side is when it was first line tenofovir-based therapy, and the right side is when that was the second line therapy. But the bottom line is this: quantitative HBsAg comes down very slowly, and in a cumulative manner was at about 1 international unit per year, and HBV DNA undetectable in 89% at a median follow-up of 90 months. So 11% still had HBV DNA positive way out, 90 months out. HBV DNA decreases very slowly, and in those with co-infection with HIV, even slower than in the mono-infected group. And so we need to be aware that we're not going to see the kind of responses we get when treating HIV, where a high proportion of patients are actually fully viral suppressed to undetectable within just a couple of months. Now, the other aspect of looking at those guidelines is asking the question of the use of ALT and why that is significant or important, and why there is controversy that often leads one to think about a liver biopsy. There's several studies that look at this. This is one, and I think it's useful and instructive to look at the data. The top graph is looking at stage of fibrosis in a group of patients with chronic Hep B who have PNALT, persistently normal ALT, defined as 2 ALTs less than 40, so they chose less than 40, over at least 6 months. And if you look at the fibrosis, you see that a little over 65% were fibrosis free, but 35% already with PNALT had fibrosis present. And as the ALTs go up, the level of fibrosis overall increases in each of the fibrosis stages, with stage 4, the black, or this line here, being cirrhosis. If we look at the ALT versus inflammation, and remember that inflammation is the precursor to fibrosis. Inflammation is injury, injury raises ALT, repair of injury leads to scar or fibrosis. Even in those with persistently normal ALT, by the definition used, like 5% had no inflammation. And everyone else had some degree of inflammation present, ranging from mild, moderate, severe. And again, the proportions go up as the ALT goes up, because ALT is the marker of inflammation. This is why we typically consider a normal ALT now to be 30 for men and 19 or 20 for women. And if you use those numbers as your guide, then anything above that suggests that that patient has an inflammatory process present and may be at risk of developing liver fibrosis. The last thing when thinking about our patients and how we treat them and when we treat them is related to the issue of hepatocellular carcinoma. And the classic study looking at the relationship of HBV DNA to the risk of liver cancer is the REVEAL study. This study, national study done in Taiwan, looked at development of liver cancer and shows us that the two things: higher levels are associated with a significant relative risk of developing cancer over time, but that risk begins to appear at even very low viral load levels. At levels down here, the relative risk is 2.3, and the difference is statistically measurable at levels above 300 international units. So detection of HBV DNA not fully suppressed is probably associated with a continuum of risk, which is why we'd like to see, whenever possible, full suppression, understanding that that is a slow process and not always achievable in all of our patients quickly. What was done in this patient? Well, treatment was initiated with a nuke based upon her ALT level, a family history of hepatocellular carcinoma, the presence of a high HBV viral load, and you have to consider the patient. The balance that you're always weighing, and the argument that comes up in consensus guidelines committees, is when you make a decision to treat a patient, the decision is focused around lifetime or long-term therapy. And do I want to commit this patient to taking a pill for the rest of their life and the cost of doing that? Or do I want to wait until it's much more clear that this patient is in danger? And that view varies considerably within the consensus guideline groups, which is one of the reasons we see such differences. I believe firmly that you need to discuss this with your patient. Your patient plays an active role. In this patient, she was anxious. That's why she convinced her primary care doc to seek a second opinion, because her mom had liver cancer early. She wanted to be treated. She is on treatment at this time. Second case, 45-year-old man is referred by his primary care physician after he notices dark urine for 4 days and seeks care. He reports recent high-risk sexual exposure. He's never been vaccinated for Hep B. There's no personal or family history of liver disease. He has nausea, vomiting, anorexia, fatigue. He's alert and oriented ×3 without asterixis. His sclera are icteric. His abdomen is tender on palpation in the right upper quadrant. His ALT is 1,856. His AST is 1,567. He is very jaundiced. His bili is 14.3 milligrams per deciliter. His anti-core IgM is positive, and his HBV DNA is 1.8 × 10 to the 7th. His INR is 1.4. HCV, EIA, and RNA are negative, as is HIV, and a Hep A IgM is also negative. A right upper quadrant ultrasound shows an enlarged echogenic liver with no ascites. He's admitted to the hospital, and the ward team attending called me and said they had curbsided GI in the hall and thought that they should start nukes right now in this patient because his liver enzymes were so high and he was so jaundiced. Let's see what the guidelines say. The AASLD says the indicators for therapy in the setting of acute hepatitis B, which this patient has, is a bilirubin greater than 3, an INR greater than 1.5, hepatic encephalopathy, or ascites. Well, so he has one of those. EASL, European Association, says patients with coagulopathy or a protracted course should be treated with nukes and listed for transplant. Well, he doesn't have either of those. APASL, Asian Pacific Society, just to remind you, treatment is only indicated for patients with fulminant hepatitis. And for those not familiar with the terminology, fulminant means hepatic encephalopathy, which he does not have, or protracted acute hepatitis B. He just appeared, he just presented. Up-to-date guideline, treat patients with severe disease defined as an INR greater than 1.5 or persistent symptoms or marked jaundice defined as a bili greater than 3 for more than 4 weeks after presentation. Treat to reduce likelihood of reinfection post-liver transplant if you're going to do transplant or if you're contemplating transplant. There's very little data from organized randomized trials regarding acute Hep B. This is one study from India looking at the use of lamivudine versus placebo in randomized trial, looking at what happens when one treats. 71 patients, acute Hep B. There was no difference in morbidity or mortality with treatment. There was no difference in rate of chronicity. The trend was towards a lower likelihood of having protective anti-HBs at 1 year in those that received treatment. And there have been other case series that have argued that you could increase the risk of chronicity by treating, though that was not seen again in this study. So this study suggests that treatment for acute Hep B generally should not be treated. What was done? HBV treatment was not initiated based upon the absence of meeting the definition of fulminant hepatic failure. Watching the patient showed an improvement in transaminases over a 2-day hospital course, despite rising bilirubin. So the second important takeaway on this case is it's important to know that bilirubin will continue to rise even as the liver heals and the injury falls back, that injury stops, but bili goes up because new hepatocytes are not connected for a while, sometimes for several months, to the bile canaliculi that will transport bile, bilirubin, out of the hepatocyte. So bilirubins often continue to rise. That tends to scare clinicians that don't deal with this, and again, forces people to think about treatment or even liver transplantation. But we said, stay calm, don't do anything. 1 month later, a patient's liver enzymes were normal, and the patient had developed anti-HBs and anti-HBC in serum and did just fine. The risk of chronicity in a non-immunosuppressed adult is well under 1%. So we're not that worried about this patient developing chronic disease following symptomatic hepatitis B infection. If his INR continued to rise, we would have listed him for liver transplantation. And at that time, we would have started nukes, trying to drive down viral load to prevent reinfection in a new organ, and then using HBIG with nukes for years to a lifetime in that patient to prevent reinfection. I received a number of questions, and I get calls regularly about when to stop. So that's what this case is about. 52-year-old man with chronic Hep B is self-referred for a second opinion. He was diagnosed with hepatitis B approximately 10 years ago and was treated with tenofovir for 7 years. The tenofovir was started because he was HBeAg positive with a viral load of 1.2 million and an ALT of 65. He had undergone a liver biopsy and it showed minimal fibrosis, but inflammation was present per the report. Recent testing revealed hepatitis B E antigen loss and E antigen appearance. His HBV DNA was undetectable, and a transient elastography was done and suggested F1 fibrosis. His physician wanted to stop the tenofovir, but he was reluctant because he's been feeling great and does not mind taking this long-term medication. No side effects, covered by insurance, not an issue. What do the guidelines say? AASLD says HBe antigen positive adults without cirrhosis who seroconvert, if they discontinue nukes, it should be after a period of treatment consolidation, but the quality of evidence is very low. The EASL guideline says HBe antigen seroconversion with 12 months consolidation, meaning continuing the nuke, plus undetectable HBV DNA. APASL says HBsAg loss or seroconversion after 3 years of virologic suppression. And up to date says HBe antigen seroconversion confirmed by testing on 2 occasions, at least 2 months apart, with 12 months continuation and close monitoring every 1 to 3 months for at least a year. And I did get several questions about monitoring of patients. An alternative is to continue treatment for HBsAg loss. This is a study looking at durability of after seroconversion. The relapse rate in this group of patients was 70%. 30% maintained serologic and ALT or inflammation remission. And over 35% of the group that relapsed ended up having a seroreversion. This shows the time course of relapse. First, it's not necessarily quick, which is why you need to monitor patients. The time to relapse took place over an 18-month period, and then the curve flattened and the remainder didn't relapse. So you never know when that's going to happen, and that's one of the reasons you need to continue to monitor those patients. What was done in this patient? We recommend a continuation of tenofovir for at least another year because the timing of seroconversion was not well documented in this patient. We just found out about it from the testing a few weeks before in his primary care office, but it had not been tested before that for several years. And the patient had anxiety. Again, talk to the patient. Patient had anxiety about drug discontinuation. However, we recommended monitoring with consideration a future trial of discontinuation because this patient does appear to have a low level of fibrosis. And therefore, if he flared, his risk of flare with severe liver injury in the setting of seroreversion would likely not be as dangerous as if he had more advanced liver disease. So again, factors that you take into consideration are where is this patient in their liver disease? If a patient is cirrhotic, you never stop therapy. If the patient has advanced fibrosis, F3 on the Medivir scale, you're probably never going to stop therapy. F2, you're going to have a serious discussion and close follow-up. And F1, you're a little more comfortable after a year to 2 years of consolidation with treatment after a documented seroconversion. Next case, occult Hep B and reactivation. A 51-year-old woman with a recent diagnosis of breast cancer, metastatic to bone. Consultation was requested by oncology because the patient reported a history of HBV as a preteen growing up in India. Hepatitis panel was ordered by the oncology team and revealed that she was HBsAg negative, hepatitis B anticore total positive, anti-HBs negative. And again, several of the participants for this meeting wrote in and asked about this situation, either because of the antibody situation, the anticore positive, or because a patient is going to be on some sort of immunosuppressive therapy. The question that I got from oncology was, should we give this person a booster vaccine for Hep B or start a nuke right now? Let's see what the guidelines say. The AASLD says a hepatitis B surface antigen negative, anticore positive patient with undetectable HBV DNA should be monitored during chemotherapy and nucleoside analogs administered if HBV reactivation occurs. But if rituximab is included or stem cell transplant patient, start antiviral therapy now. EASL says HBsAg negative, anticore positive patients should receive anti-HBV prophylaxis. Pretty clear. Start treatment. APASL says HBsAg negative anticore positive patients with undetectable serum HBV DNA should be monitored and receive treatment upon reactivation. Up to date, recommend antiviral therapy to all patients who develop reactivation, defined as HBV DNA when none previously, or 1 to 2 log increase if it was present before, or if there's seroreversion. And ASCO, American Society of Clinical Oncology, patients with past HBV undergoing chemo not associated with high risk of reactivation should be monitored every 3 months for HBsAg and ALT, antiviral therapy only if HBsAg becomes positive, or if HBV DNA greater than 1,000. Again, a wide variation in the guidelines. ASCO also writes, there is a lack of data to accurately ascertain the risk of HBV reactivation by anti-cancer class of specific drug, apart from the established high risk of anti-CD20, that's like rituximab, monoclonal antibodies, or stem cell transplantation. There's one more major guideline, and this came from the AGA. They divide patients into low risk, moderate risk, high risk. And I feel that this guideline is in many ways the most useful in addressing specific situations related to the patient at hand. So the guidelines in each of the risk categories divide the patient up into characteristics. This is like either HBsAg positive, anticore positive, or HBsAg negative, anticore positive with these agents, including, someone asked in their questions about imatinib, or a patient like ours, HBsAg negative, anticore positive, patients taking moderate dose of prednisone or equivalent or high dose prednisone, corticosteroids, or patients taking anthracycline derivatives like doxorubicin. And in those, we start antiviral prophylaxis and continue for at least 6 months after discontinuation of the immunosuppressive therapy. That also was a question from one of the call participants today. How long? 6 months after the end of the chemotherapy. So what did we do? HBV DNA was checked and was positive with a viral load of 186. So this patient did have occult Hep B. So that's the first thing, check at HBV DNA. Discussion with the oncologist revealed that she was going to use a doxorubicin-based chemotherapy. So the patient was started on NUC, monthly monitoring of ALT and HBV DNA were recommended, and the patient actually proceeded through a course of chemo and has done well, is still in her 6-month follow-up period. Okay, case 5, vaccination. This is a 47-year-old MSM with HIV infection. HIV was diagnosed 12 years ago, and the person has been on ART since then, most recently switched to a 2-drug regimen of dolutegravir lamivudine 6 months ago. The patient has been vaccinated 10 years ago for Hep B with Endurex B, 20 micrograms with 3 doses. He reports high-risk sexual exposure several times per year. 2 years ago, a booster of Endurex B, 40 micrograms, so what we would call a double dose, was given 1 time. Recent testing shows HIV fully suppressed, CD4 487, HBsAg negative, anticore negative, anti-HBs negative, HCV EIA negative. Consult from my ID colleagues. Would I repeat a full double dose 40 microgram vaccine series, or is he protected because he's on this regimen containing lamivudine? let's go to the guidelines. The CDC says primary vaccination, 3-dose single-strength vaccine or combo vaccine, no specific recommendations about Hepatitis B, a newer vaccine, but if 2-dose regimen is preferred, this is an option. For revaccination, that's where our patient would fall, 4-dose, double dose, or consider Hepatitis B with isolated anti-core, 1 standard dose, check antibody in 2 months. If less than 100, repeat with a single or a double dose. EASL, repeat doses until anti-HBs greater than 10 milli-international units, which is the protective level of antibody against infection, or greater than 100 according to national guidelines. In order to reach 100 in non-responders, repeat 3 doses if less than 10. 1 dose if less than 100. Consider double dose, particularly if the person has low CD4 or a high HIV viral load. AASLD, for those with HIV on dialysis or with cirrhosis, use a double dose of vaccine. Up to date, for most patients, we suggest conventional recombinant Hep B vaccines rather than Hepatitis B. Why? Because there's no data in HIV. The decision to use an alternate strategy is dependent on multiple factors. Patients who have 2 anti-HBs, 2 complete vaccine series are considered non-responders. So this person, technically, by that definition, is not a non-responder. Okay, what factors affect vaccine response? Well, HIV with a almost linear relationship rather than a cutoff relationship to CD4 count. Transplantation with immunosuppression reduces response. Use of immunomodulatory drugs. The presence of chronic liver disease with or without cirrhosis. Older age, less responsive. Men worse than women. Presence of diabetes, chronic liver disease. And then the vaccine type, dose, and site. And if occult Hep B is present, you can't vaccinate the person because they have Hep B. What about that idea of the patient is on lamivudine? Well, the use of ART is potentially protective at some level, but not 100%. So you can use these agents. They do provide a pre-exposure prophylaxis, but we probably shouldn't be relying on them and should be trying to vaccinate our patient. And LAM is potentially a problem because there's a very low barrier to resistance. In HIV, overall response rates to primary vaccination range from 35 to 70%. And people have tried different strategies: higher dose, increasing frequency, altering dosing site, and addition of adjuvants. In the classic study from Launay at the French ANRS, we see that comparison of 4-dose, double dose, 40 microgram IM or intradermal, both were better than standard dosing of 3 doses, 20 micrograms. And in a follow-up study in the same cohort, the protective antibody at 10 milli-international units per ml persisted at the highest level in the group that received the double dose 40 microgram dose. Recently, a meta-analysis combining data for long-term results confirms that indeed this should be the standard of care in HIV positive persons, that we should be starting with a double dose vaccine series, either 3 or 4 doses. We don't have sufficient data to say which it should be. Revaccination is another story. In a follow-up from the ANRS in patients that failed to respond. They went back and repeated double dose or single dose series, and there was no difference. Though there was a slight numerical advantage to the double dose, there was no statistical difference in overall response rates, and they did power it to show a difference. The newest player on the market is Hepatitis-B. It is a CpG, cytosine guanine, which binds, is a TLR9 agonist that binds to improve innate response in dendritic cells and memory B cells. In its FDA registration trials in different age groups of patients or those with diabetes, it achieved superiority over standard Engerix-B, leading to its approval. In a separate study that it is not licensed for, it was compared to double dose in dialysis patients. Double dose or 40 microgram dose is approved in dialysis patients, and it achieved superiority over that dosing in this group of patients. Hepatitis-B in HIV, we are starting to see in the last 4 to 6 weeks the appearance of single center studies reporting results where the vaccine has been available. This is a study in a Ryan White clinic. Its results are similar to other studies. 87 patients received the vaccine, 2 doses of the vaccine, because that's how it's approved. The overall SPR rate was about 85%. That's pretty good compared to our historical norms with Engerix-B. It was lower, just over 50%, in those identified as prior non-responders. I would like to point out that for those of you that are near ACTG sites, there is an ACTG trial looking at 2 doses of Engerix-B versus 3 doses, or 2 doses of Hepatitis-B versus 3 doses, versus a repeat vaccination series with Engerix-B, randomized, blinded trial. And so be aware that that's out there. And if you can, I encourage you to refer your patients. What did we do? This patient was referred to the ACTG trial, which is going on at my site, after a discussion of giving him the empiric Hepatitis-B 2-dose regimen. Furthermore, we discussed the risk of a 2-dose ART regimen in the setting of high-risk sexual behavior, the theoretical risk of LAM breakthrough, or of being exposed to an already LAM-resistant Hep B strain, or if he already has occult Hep B, but we're not detecting it in him because it is being suppressed by the LAM that he's on. So we really recommended that at this point he not be on that regimen. I'm going to finish very quickly with saying it's clear that with this plethora of guidelines and complex treatment decisions, that we need better therapy. We need better therapy because it's complex and because we can't achieve even functional cure in most of our patients. We are looking, there are studies going on at all stages that we see here with a variety of strategies that are both virologic and immunologic that approach this from limiting entry and uncoding, DNA process inhibition, trying to improve our reverse transcription, finding ways like Cas-CRISPR to cleave CCC DNA, or to deal with virion assembly inhibition. There are studies looking at therapeutic vaccines, immune stimulation, but we're not there yet. So let me finish by saying guidelines are suggestions. They don't always give us the definitive answer, and the situation with your patient may not be exactly what the guidelines describe. HBV management is complex. If you're uncomfortable Seek help. Don't be shy about speaking to an expert. Treatment goal is complete suppression of HBV DNA using a sensitive assay. All HIV-infected patients with HBV should be on dual active therapy, but HBsAg clearance with long-term suppression is rare. Acute HBV should not be treated unless liver failure is present or transplant is contemplated. Stopping suppressive therapy is risky and generally should be avoided, and we really don't do it in people with HIV because they should be on dual therapy. Other modalities are needed to clear cccDNA and achieve functional cure. And I didn't really talk about it, but all patients at risk following various guidelines should be screened with HCC every 6 months with ultrasound at least, perhaps with ultrasound and alpha-fetoprotein. Our practice is to screen all HIV positive patients co-infected with hepatitis B. We're going to go back to our questions and see if any of you have changed your answers. So these were the questions. Which is true regarding hepatitis B? Please record your answer. Okay, so definitely a change from what we saw before. Let's run through these quickly. The first one, no one chose. Acute Hep B frequently leads to fulminant hepatic failure. No, it is rare. In a non-immunosuppressed adult, it is under 1%. Acute Hep B in immunocompetent patients leads to chronicity. No, that's actually also well under 1%. Acute Hep B should usually be treated if ALT greater than 1,000. No, only if there's fulminant hepatic failure or if you are contemplating transplantation. The height of the ALT does not matter, which leads us to the correct answer, which 71% got, should be in patients under consideration for liver transplantation. Next one, which is true regarding suppressive therapy. Please vote. Okay, so we have still a split here, and maybe I still wasn't clear enough. So the first one, it leads to 95% viral undetectability in HBV HIV within 6 months. That is not true. And in fact, in the French study that I showed you, it was 90% at 90 months. So suppression to undetectability tends to be slow, and in various series ranges from 80 to 90% at best at about a year. It may be stopped after 1 year in most patients. No, most of you did not pick that, and you are correct. It is often indicated in persons with normal or near normal ALT. That is the correct answer. And it leads to functional cure in more than 50%. No, functional cure is very rare. Okay, so now you have the opportunity to submit questions using your Q&A button. I am going to stop the sharing so that I can see the button. And I am going to try and go through some of these questions here. So the first one from OSA, patient is diagnosed with Hep B based an extremely high liver enzymes viral load, cause is unclear. After a week or so, repeat labs are normal. Patient's not treated. Should patient be treated? So no, it sounds like this patient achieved a cure, a spontaneous resolution by themselves. Vivian, what is the US prevalence of co-infection of HBV, HIV? So it depends on the series that you look at, but in various series in the United States, it's between 4 and 10% overall. So Hep B infection overall is very common, but it doesn't always lead to chronicity. In a person with HIV who acquires later, and particularly if untreated with low CD4s, rates of chronicity can be as high as 20%, but overall rates of chronicity are about as high as 10% in some populations. Why not treat everyone when feasible? This sounds like the HIV era of not treating with CD4 less than 350. Yeah, that's a great question. So I think, as I mentioned, that there are strong advocates in the consensus guideline groups for not starting people on therapy because of fear of need for lifelong medication, because we don't have a cure. And yet, if you include the patients by using their ALT and simply treat when inflammation is present to prevent injury, which leads to fibrosis, I agree, and I fall on the side of being much more liberal in starting treatment if the patient is going to take therapy. So adherence is important. You can't go on and off because there is increased risk of resistance like in HIV. Let's see. Joseph Yao, will there be future recommendations on clinical use of hepatitis B core-related antigen or pgRNA, pregenomic RNA? Fantastic question. I didn't discuss those previously. Those are newer experimental, largely experimental advanced tests that are being looked at in the context of clinical trials primarily, and looking at cohorts to determine what is their place. And the answer is we don't know their place yet, but certainly our current tools, along with quantitative surface antigen, are going to be needed, I think, to use the newer tools as we think about predicting functional cure, because the current tools are no good for predicting functional cure. So they're not ready for prime time, but stay tuned, and maybe IAS will have a future lecture on new diagnostic modalities to be used. Let's see. I have a lot of questions here, and I'm trying to not just take the most recent. Wanda, HIV, HBV positive on tenofovir develops severe osteoporosis. Do you change to entecavir or treat osteoporosis, change to Descovy? So the latter, I mean, switching to a tenofovir alfenamide based regimen where bone loss is less of an issue, and then treating if bone loss is significant now is certainly appropriate. I don't think that I would try to make the regimen even more complex. Let's see. Wilfred Shu, immunocompetent patient got HBV vaccine, became HBs positive, but some years later negative. Should not need a booster dose, correct? So the CDC is pretty conservative about this and uses mostly risk-based recommendations regarding booster testing, boosters, and which group should get it. So it's really at this point tied to risk category. Clearly, when people lose antibody, they are at risk of infection if they are exposed. But you need to put them in a risk category. A 78-year-old single woman living in assisted living may not be the same risk as a single 25-year-old woman living in Miami. So I think you need to look at the risk profile of the person that's in question before making that decision. Again, there's not a single blanket answer other than targeted testing and boosters should be considered. Should tenofovir and emtricitabine, this is Morgan, should tenofovir and emtricitabine always be co-prescribed for HBV, HIV, or is tenofovir alone the only HBV active antiviral sufficient? So the general guidelines are in the setting of co-infection. We do use dual agent therapy because of the role it also plays in HIV suppression. And so the general rule is we try to use 2-agent therapy, and I would continue doing that whenever possible. This Phillips question, similar to one we had before, but with the published data on liver cancer across all viremia strata, how much longer will we simply treat chronically before we simply treat all chronically infected patients? Why not now? And, again, it's about cost and decisions about lifelong therapy. But if you use the guidelines of lower levels of ALT and make decisions about inflammation, talk to your patient, look at their insurance, their ability to pay, their interest in staying on meds, I think you'll treat more patients based upon that alone. Let's see. Emily Cartwright, if an HIV HBV co-infected person on ART with tenofovir loses HBsAg and gains antibody, can tenofovir be discontinued and switch to a regimen that, like a 2-drug regimen that will not contain an active agent? Can HCV surveillance be discontinued? And the answer is, as long as they're not cirrhotic, yes, I would definitely do that. They should be cured, but remember that that would be a definition of a functional cure. They may still have CCC DNA. I wouldn't want them, if they had advanced fibrosis, cirrhosis, to have any risk of a flare, but otherwise, I think that would be very reasonable to make that switch and simplify their regimen, maybe protect their kidneys if that was one of your issues. Do you always recommend HDV screening in HBsAg positive patients? This is from Sebastian. Or are you using a risk factors approach? Excellent question. So it's important to know that if you looked at the guidelines on this, the US guidelines from AASLD support a risk-based approach. The European guidelines support testing everyone, both from EAKS, which is the group that deals primarily with HIV, and the EASL group. So HDV is thought to be relatively uncommon in the US. However, it's clear that it is more prevalent in pockets than we previously gave it credit for among HBV positive patients. Bob Gish and colleagues did a study in Southern California and found a positivity rate of 8% overall in HBsAg positive patients. We studied this in the Cincinnati, and we found a little over 2% positive in our HBsAg positive patients. So we do routine screening, not risk-based screening, because you cannot tell from risk-based screening who's going to be positive. And so I do incorporate that, and we do at least one Hep D antibody in all patients we diagnose with hepatitis B. Let's see, the questions keep coming in, and they are wonderful questions. I don't know if we can keep going too much longer. So let me hit just a couple more here and apologize for those that I can't get to. When do we treat occult Hep B in an HIV patient? So the answer should be nowadays, always, because we treat Hep B when present, always using a Hep B active regimen as part of our ART regimen. So if you have HBV DNA present, you have a patient with Hep B infection, and you should be treating them, whether it is occult or falls into any of the other categories. Let's take one more here. Okay, so Eric. Eric has a patient, HBV HIV co-infected, on treatment, TAF-based, low-level HBV DNA, hundreds to 10,000s, previously undetectable, HIV viral load less than 40. Patient states adherence, great case. Should entecavir be added? So again, this is an interesting and very nuanced case. So the first thing you should know is that you could have patients that are treated with dual infection with HBV, HIV, and their HIV is fully suppressed, but their HBV is not, either because of some degree of adherence issues or because you haven't gotten it down yet. In a patient like this that was clear and now is not, this is a patient that almost certainly has an adherence issue, But despite the adherence issue, maybe they're taking their drug 4 or 5 days a week and missing a few doses. That is still enough to maintain complete HIV suppression, but not enough to maintain complete HBV suppression. HBV viral loads are astronomically higher than those seen routinely with HIV. So this patient is almost certainly not fully suppressed because of adherence. If they had never achieved it yet, I would say wait. And the recommendation, which I write about with Dr. Teo in Up to Date, is give it at least 2 years, unless your ALTs are high. And then you could start entecavir in that patient as a second agent on top of their tenofovir-based ART regimen. But this situation that you describe is a little different. Okay, I think it's 2:30 now, and I was told I could go 20 minutes after the talk. I know the talk went a little over, but we're now 30 minutes past that. So I think we are going to stop here. And I want to thank everyone for their participation. Don't forget CME and mock, and you have a slide here about getting your evaluations in. So thank you everyone very much for your interest, and stay tuned for future great webinars from IAS-USA.
Thank you, Dr. Sherman. As a reminder, evaluations and how to claim CME will be emailed by tomorrow, and this will enable us to view all of those that have attended today's live broadcast. A list of upcoming webinars available for sign up are available on the IAS-USA website. The next webinar is next week, titled Nothing Without a Civil Society Solutions to the COVID-19 Pandemic. And this will be a panel webinar that will include community members in both HIV and COVID-19. We have recently added a new feature to the IAS-USA website, and you may test your knowledge with the new practice questions of the week. These questions will appear as a pop-up when you first visit our website. If you have closed this pop-up or did not view it when it first appeared, you may also access this on the resources section. And here is our upcoming course on June 25th. To view the current agenda and to register, please visit our website. Lastly, we have an upcoming dialogue this Friday with Dr. Moore and Sag, who will be going over the latest on COVID-19 variants. And here's a short list of our recent on-demand dialogues. Lastly, we'd like to thank our presenter, Dr. Sherman, and to the audience for your participation. This concludes today's webinar.